Good morning, everyone, and welcome to this month's edition of Global Grand Rounds. My name is Katie, and I will be your host for today's session. Before we begin, I'd like to let you know that today's session is being recorded. We will also be using an AI generated summary to capture key discussion points, and that summary will be posted along with the recording after the session. We're delighted to have you with us and look forward to an engaging and informative presentation. At this time, I'd like to turn things over to our medical director, Dr. Pekia, who will introduce our today's speaker.
Thank you, Katie, and appreciate it very much. As Katie mentioned, I'm medical director for about the past 4 years now of global offsite care, which is, as you can see from my background, dedicated to facilitating and helping to deliver telemedicine on a global scale across numerous sites and all over the world, but predominantly in sub-Saharan Africa and Asia. And part of our mission is collaboration with our colleagues at those sites and elsewhere. And so glad to have Dr. Ray Hruby, DO, MS, FAAO, distinguished from Western University of Health Sciences, where he and I are both on the faculty teaching and mentoring students. I also have known him, although we were at different times at Michigan State University's College of Osteopathic Medicine. I was a student there in the past, and later on, Dr. Hruby was faculty there for about 5 years or so. And fortunately for Western U, he's been with us since the late 90s, was fully active at Western U from 1999 to 2009, retired from that position, but continues his work at Western U as a professor and consultant to the Department of Neuromuscular Medicine and Osteopathic Manual Medicine. I need to mention he trained at the College of Osteopathic Medicine and Surgery in Des Moines, Iowa, and then subsequently interned at the Osteopathic Hospital of Maine in Portland, Maine. He's involved in teaching research and curriculum analysis and development, as well as mentoring new faculty and pre-doctoral osteopathic manual medicine fellows. And he is also involved with Western U's interprofessional education program. So today's presentation, he will explore research on whether osteopathic manipulative treatment, otherwise known as OMT, can enhance the immune response to COVID-19 mRNA vaccines. He'll be reviewing the scientific reasoning behind lymphatic pump techniques and how improving lymphatic circulation may support immune function and antibody production. The talk also presents findings from a randomized clinical trial examining the effects of OMT on antibody levels, symptom severity, and medication use following vaccination. And without further ado, it's my honor to welcome back and present our speaker for today, Dr. Ray Hruby.
Thank you, Dr. Pecky. I appreciate that. Good morning, everybody, and welcome. At the moment, I can see people logging on, and I see some students and colleagues and friends and family from Western University. So I'm glad you're all here and hope you'll find this interesting. So as Dr. Pecky has said, this is a little bit more of a talk about the use of osteopathic manipulation, particularly what we refer to as lymphatic treatment, or techniques that we use that affect the lymphatic system, either to increase or augment flow or to increase the immunological impact of the lymphatic system. And I'm glad to be able to present this in view of this study here that you see on the title slide. This was a randomized clinical trial that we had a couple of years ago during the pandemic, and we'll get into it. But in a brief statement, DOs for long years have used these kinds of approaches to various infectious diseases. And over the years, we've slowly accumulated more and more of an evidence base for it, starting with smaller studies, later on with some animal studies that you'll see here, and finally, and most recently with this study, which was a study on human subjects during the pandemic, during the time. And it's a strange situation, I think, when you have an opportunity to do a study like this and in the middle of a pandemic, in the middle of almost the lockdown that we did. And the study was conducted over a year, and it turned out pretty well. And there's still some ongoing things going with this study. You'll see as we present it that not only did we get the information we were looking for in our hypothesis, but there was notice that there are a number of little subgroup things that came up, and I'll mention them quickly later on, and some of that is still going on. But we'll get started here and look at things. I have a certain amount of background information. First of all, the usual conflict of interest disclosure. And basically what we're going to look at is these objectives. So we're going to look at the reasoning behind this, some discussion of mechanisms of action. Why does this manipulative treatment, or OMT, seem to work in these conditions? Or at least what do we propose for that? And what are the benefits? What did we get? And what is the real clinical usage of this? So typically in osteopathic medicine, we believe that OMT, particularly including what we call lymphatic pump techniques, we have a whole collection of techniques that we categorize as lymphatic techniques. In fact, a lot of the techniques are simple OMT techniques that can be used for a lot of conditions. But there are some, including these pump techniques that we'll explain a little bit more about, that do directly affect the immune system itself, particularly the lymphatic system, in terms of, as I said before, improving the flow of lymphatics, augmenting the flow when needed, and particularly helping to trigger the immune system response to the lymphatic system in different conditions. The idea about OMT to enhance the efficacy, the effectiveness of the vaccine is one potential that was studied here. And we'll review it just briefly, but there's some history of that, previous studies done that seem to show that these type of techniques were affecting the immune system in this way. But it just took a long time after some smaller studies, and then later on some animal studies that were pretty clear. And then finally, particularly this study that was at least large enough to be a big improvement in the idea of how we can explain or show how this type of technique works. So as we know, I know that a lot of you on the system right now are DOs or DO students, so this is somewhat old history to you, but for those that might not be familiar with osteopathic medicine or its OMT techniques, this type of treatment is meant to reduce these myofascial restrictions that people can get, and by optimizing what we call the vascular phase in the lymphatic system, meaning the flow of the fluid throughout the body and the tissues of the body. And some of the specific techniques, then as the lymphatic system responds and puts out more immune system products to help defend the body, then the body gets a much bigger defense system along with everything else that you're doing. So we want to improve lymphatic flow. And usually, as you'll see, these are done by applying a kind of external pressure through motions on some of these techniques that we would consider to be oscillatory, hence the word pump for certain pump techniques, as we call them. And so applying and releasing pressure in a rhythmic fashion is what is understood here. So and it helps move the lymph through the system, and also, of course, any of the system products that it may be carrying. And it can help certain techniques help to stimulate the production and distribution of some of these lymphatic products as well. Again, we talked about this idea of small-scale animal studies and other clinical studies that have been done over the years to give you a little bit of a sense of what I feel is like the historical development from just clinical observation to kind of case reports to very small clinical trials that are done much as 30 years or more ago, to more recent animal studies, and now this type of study to help further the knowledge of this kind of system. That a lot of this is steeped in the history that comes from the Spanish influenza pandemic that occurred in 1918, And if you're not familiar with that, what happened during that study, it was a pretty devastating worldwide pandemic, obviously. I think if you say pandemic, it means it's worldwide. So I guess that's a duplication of terms. But a lot of people succumbed to the Spanish flu, and a lot of people died during that pandemic. And so these are days when there was not a lot of knowledge about that type of infection. There were no vaccines available. There were no drugs available. In 1918, there were barely any antibiotics around, and that was, of course, was a viral infection, so they probably would likely have had little effect on it anyway. But Osteopathic Association back in those days asked osteopathic physicians to basically to write into the AOA and let them know what their experience was with treating patients during the Spanish flu pandemic. And in those days, if you look at it now, it was not it wasn't a survey, it was just a request for information. And in those days, it was still not uncommon for some research to be done that way. If we look at it today, we don't think of it as, it's interesting, and I can give you the results of that, but we would look at that type of information today as not being as rigorous as a designed kind of survey study that we would do today. So hence, as good as that outcome was for the osteopathic physicians in that time, the major critique of that information was that it was not gathered in a clear kind of standard way. DOs would simply write to the AOA, identify themselves, and give information like how many cases of Spanish flu did they see, what did they do with them, and what was the outcome. And the short sentence is, overwhelmingly, DOs reported seeing cases using their T techniques along with other things. And I actually went to our library. Our library here at campus has a collection of all of the journals of the AOA since its inception. So I read through some of those journals between 1918 and 1920 and read some of the reports these doctors sent in that accumulated this. In the end, they had over 100,000 cases of Spanish flu reported. The morbidity and mortality was incredibly low, as reported by the DOs. The mortality was in the realm of 3 to 5% or something like that, and the morbidity was very low too. I don't remember the exact percentage, but low, like 10% or so, something like that. Whereas just standard medical approaches of the time had morbidity and mortality rates spent in some localities as high as 60%. So the difference, although this reporting wouldn't be considered as rigorous today, the difference is so wide that something must have happened. Hence, there was always an interest in trying to find out more about what this did. And so as these research projects evolved over the years, we have finally gotten to this type of thing. That's our study here is an example of a more controlled, randomized clinical type of trial that seems to show basically the studies that were done over the years seem to be showing similar effects. You could test these techniques and see that people were getting increased antibodies and things like this. But the studies weren't very large sometimes. And so the idea was that the techniques that DOs felt that they were doing during that type of pandemic that gave them the good results seemed to be shown in these subsequent studies, that it seems to indicate that what we think we're doing with these lymphatic techniques appears to be doing it. But the question is getting to a study where you can study this in better detail and kind of track the mechanism of action and get some more objective results of things. So what we're going to look at, we'll look at some of the early research here momentarily. We're going to show how the study was done, obviously give the findings, and then explain what at least what we're doing here on campus towards our own next steps for this kind of thing. This thing, I may go through this a little bit rapidly for a number of reasons. There's a lot of stuff in here, so I don't mean to try and shortcut it, but some of it is a little bit repetitive. There's a lot of immunology in here. I will admit to you that I am not an immunologist. I shouldn't admit this in front of my own students and stuff, but I went to school so long ago that I learned the state of the art of immunology when I was in school in 2 lectures, all right? That's what we knew about immunology, okay? But you'll see what we have here, and I give you a little progression of these studies in short order So, and also you see some of these data presentations, our research assistant is quite a handy guy at figuring out cool ways to present data. So there's a lot of neat little graphic slides here that'll help illustrate this type of thing. So this slide is just showing what we're going to mention, at least a few sentences of studies that were just determining the kind of flow that went along, particularly in the thoracic duct. And you can see the time span on some of those. Recruitment of leukocytes in the Galt tissues was some studies directed at that at one time. Other studies that measured immune system products like T cells and antibodies and things like that. And then finally, there's at least one study that has to do with demonstrating something about antibiotic delivery in certain infectious problems where lymphatic treatments were used too. And I'll give you those results in summary fashion here. So you see a lot of graphic data, and to cut through the data a little bit, this is what they refer to as the leukocyte flux, so measuring white cells and other kind of products during lymphatic pump techniques. And there are several pump techniques. We commonly talk about the one in the middle, what we call the thoracic lymphatic pump. And there is a version of the lymphatic pump called an abdominal pump, where you actually put intermittent pressures over the abdominal wall to do that. And then comparing it to physical exercise. As we know, the immune system works a lot by the propulsion of the fluid through the system, by the action of our diaphragms and our muscles as we move around every day. Physical activity has been shown to also produce some of these results as well. These graphs are all just showing, for example, when you can see start and stop here, when the actual technique or the exercise activity was being performed, you see an elevation in the amount of fluid that's being pumped through the system, and then different blood circulatory products like leukocytes and other immune system products and other things can be measured during that time as another effective objective measure. And again, this is the leukocyte information. These two graphs are just there. Again, the data shows the increase before and after the technique. And the graphs are also used in the current study that we used on the patients. We did this similar type of data, but also did some what they refer to as area under the curve calculations, meaning that in addition to seeing the numbers, the graphic representation under the curve gives you a sense of the size, the impact of the technique and how it was effective in terms of how much fluid was put through the system at a given time. These are studies that looked at measuring what I would refer to as lymphatic system products, or so things like cytokines, leukocytes, et cetera, et cetera. And there are some studies that measured specific antibodies, as you'll see in a moment here. It's like this. So again, this is in the thoracic duct, and you can see there's in each of these, there's a rise and a fall and a rise. And this is when they mentioned that it's repeatable up here in the title. That was a study to just simply show that during the technique, you can increase the lymphatic system's activity. There's a pause, and you do it again, and you get it. So in other words, every time you do the technique, you get this increase in lymphatic flow and increase in circulatory products in the system. And by pausing it, just gave at least this amount to show you that it is repetitive. And in those days, in the time of, for example, of 1918 and around those areas, somebody who was severely ill like this, it would have been common for the osteopathic physician to be there with the patient and or to teach someone like a family member some of these techniques that can be done easily that way. And so that in the face of no other treatments involved, no antibiotics, no vaccines, this is the type of thing where they felt they were stimulating the immune system. And so this could be done repetitively, meaning it could be done every so many hours or so many times a day, for example, this type of thing. In kind of a very rough analysis, I'd say if this were an antibiotic, for example, or a medication, you could do it 3 times a day, just like you'd ask somebody to take a pill 3 times a day. You could stimulate their system. I know when I was an intern, the hospital I worked in, physicians would put patients in, and as the house officer would be called upon as an intern, the orders would be written that way. Learn to do rib raising, which is one of the techniques. Q 4 hours, for example, for the patient, or every shift in the hospital or something like that. And the DOs those times use these techniques along with other things like good nutrition, fresh air, plenty of fluids, and bedside exercises, either passive range of motion exercises to keep circulation going, or the patient had certain things to do. So they used these sort of natural methods, if you will, and they got these rather incredible results during the 1918 pandemic. So these follow-up things, here's now we get to the animal studies. This is a rat study with strep pneumonia. And all of this stuff over here is lymphatic pump plus either regular treatment or sham therapy, et cetera, or lymphatic pump with antibiotics, sham with antibiotics. But the bottom line of all this stuff is that if you look at the little lines here, we had a control. We had the lymphatic pump technique, which is the blue line here. So basically, this is showing that in people with this bacterial infection or in these animals, that the stimulation using these kind of techniques showed that the OMT was more effective than the other, even the antibiotics alone, in terms of producing an immune response and faster recovery from these kind of things. It is interesting, and you may be wondering, what kind of OMT do you do on lab rats? I think that's a separate workshop. I can only tell you right now, for the sake of time, that I was involved in a study a long time ago. I worked at University of New England for a while, and I got involved in a similar study to this with a couple of the basic scientists, and we developed a certain way of treating these lab rats, and we were getting similar. It was a different kind of study, just looking at the inflammatory response in them. But the OMT proved effective above and beyond inflammatory agents and shams and controls on these animals every time. And in case you may be wondering, or if you're ever on Jeopardy, and I'm one of the categories, I still claim to have treated more lab rats than any other osteopathic physician that ever lived. No one's ever challenged me. I believe I'm up in the realm of 700 or 800 lab rats that I've successfully treated. But anyway, you can see how that we progress from these sort of observational studies to animal studies. And so we have studies looking at titers, looking at some studies now have shown changes in hospital stays and things like that, improvement in morbidity and mortality, measuring circulatory cytokines, for example, and the certain the positive clinical outcomes by the picture here. I'll tell you what those are. The positive income wasn't the ability of the patient to go jogging only. There were other things. So some of the review of the previous information, these go back some ways. This study was done at one of the DO schools way back in 1998, where basically the students that had to be vaccinated for various things, including hepatitis B, before they went on rotations, made a good collection of people who were the captive audience of medical students available for a study. And I remember this, what they did was all of the students got the vaccination, and then a group of students for, I think it was 6 weeks, they got the lymphatic pump technique done to them twice a week for those 6 weeks. And then they measured their antibody levels to hepatitis B in the beginning, and then during, and then later on at the end of the study. Basically, the idea there was that at the end of the study, all of the students were successfully immunized by way of measuring their antibody titers. Their titers were high enough to be immunized. The students that got the lymphatic pump OMT actually had higher antibody levels, and they reached those levels sooner than the group without OMT. So you see some of these studies began to show some objective idea that the techniques were doing what we thought they were doing in that regard. As an example, this study was a study on patients in the hospital, elderly patients who are hospitalized for pneumonia. So it's a bacterial kind of study. And again, a lot of data showing here, but what happened here was the patients who received OMT during the hospital, which included these lymphatic techniques, ended up having shorter hospital stays, the shorter duration of medication, meaning they were able to get off of IV antibiotics sooner than patients without the OMT, and there was less mortality in this group and less respiratory failure. So the studies are gradually showing more effectively and more objectively what we can do. There's a lot of little things here, but the bottom line of all these little bar graphs and everything is that the techniques have been shown to very rapidly induce changes, meaning increases in levels of circulating cytokines, leukocyte profiles, and in the caption, some of the other immune products like IL-8, et cetera, et cetera. Okay. So we're getting there. And this study was a somewhat smaller study, but it kind of showed a little bit about some of the other clinical effectiveness. People reported a greater acceptance of the OMT as part of their treatment. They felt better, they had greater satisfaction, better breathing that they reported, et cetera, et cetera. And this was done on hospitalized patients and mostly verbal collection of this kind of self-reporting from the patients. But again, it was a positive study. So the idea was to show that patients could improve, obviously, by this type of treatment and have a better effect. So we're going to evaluate the OMT on these patients with these immunological and clinical outcomes following their vaccination, and figuring that they will have better antibody titers, et cetera, et cetera. Again, so the mechanisms of action, or what we were doing, and I think I can go through this, not to shortcut it. This is the highly sped up version of the protocol that we use, and we'll talk about this in a second. But you can see we have a myofascial release here at what we call the thoracic inlet, followed by a pectoral traction, which opens up the chest better, diaphragm release, and a splenic pump to increase the circulating immune products, and of course the thoracic pump. That's the warp drive version of the lymphatic protocol shown. So you can see, I'll mention it now in case I forget later. So what we've done in this study was these 5 techniques. This was a 5-technique protocol designed purposely for the study. As there are, you can do a protocol like this in any kind of clinical study, or you can use what we often call a treat what you find study, rather than a specific protocol that every patient receives the same techniques versus what somatic dysfunctions do they have and what do you want to use to treat them, meaning treat what you find, or in some of the European literature, they call it the black box approach, like you don't know what you're going to treat until you examine the patient. And there are pros and cons for using either method, but we chose this. Not only was it a 5-treatment protocol, there are other lymphatic design techniques, but each of the techniques was done under time situation, so each technique was done for 1 minute. In the end, in terms of clinical application, you're talking about literally 5-minute maximum treatment done to a patient to help assist them to overcome an infectious problem like COVID. What happened here was we had a sum total of 104 patients. The 2 groups were formed. All of the patients received a vaccine. They received a 2-dose vaccine, one injection, followed in 4 weeks by the second injection. And the control group basically received the injections, and then give you a little more detail. They were tested for antibodies prior to the first injection, and then several times through the study protocol as they came for follow-up visits. The OMT group got the vaccine, and they also received this lymphatic protocol on the day of the vaccine and the day after the vaccine, and the same thing for the second dose of the vaccine, and then had the same blood draws as the control group. And so the comparisons were made in that way. This is, again, just another view, our research assistant giving us a very cool visual display of the timeline. So vaccine followed by, if you're in the treatment group, OMT that day and the next day, okay, second vaccine 3 weeks later. This group over here, during this time, at the time when we were doing this study, we just happened to hit it where there was also the development of a number of subtypes of the COVID virus itself. We noticed that we had to keep track of what subtypes were going on. And then during here, they were especially looking at those subtypes. And then this particular, the treatment group also, if they were in this part of the study, they would get actually a booster shot at this point, and then 2 more OMT treatments. But most of the people were in this group here, okay? Again, we also saw that there were some people that had breakthrough infections, so we had to keep close track of which people had breakthrough infections, and were they in a group of people who were what we call naive to COVID. That is, they showed no evidence of any previous infection with COVID before they started the study. Or in some people were in both groups who may have had COVID in the past, and they already had a certain number of COVID antibodies. And so we wanted to make sure we knew who those were as we looked at breakthrough problems and side effects and things like that. This is a real hard study to see, but it's just telling you that almost the same thing, okay? IgG levels measured at these certain times. These antibody levels again on the same timeline. And then we kept a log of all the side effects, symptom severities if they had side effects, any other medication that they used during the time of the study, that type of thing. Watched for adverse events, and of course kept close track of the compliance of the patients, kept track of those. So there's a lot of telephone and face-to-face follow-up with these patients to make sure we got as much data as we could. This, I will say just rapidly, the PowerPoint is available if you really want to look at this in detail, but for those that might not be familiar, this is just a little description of the techniques. We did what we call MFR, or a myofascial release of this thoracic inlet. Pretty much we go to school, we learn this as a thoracic outlet. I know in standard terminology, the DOs like to call it an inlet, since that's like the terminal area where all the venous and lymphatic flow comes back into the central circulation. So we use this MFR technique on the thoracic inlet. There's a picture of it. There's a step-by-step way of doing it. And we don't necessarily have to read through all that right now. We did a pectoral traction technique. You can see the anatomy here. The pectoral traction, as you see by the photo here, is simply the hands placed on the lateral parts of the pectoral muscles here. And a traction is put on and held to stretch these tissues, open up the rib cage and open up more of this thoracic inlet and the whole rib cage a little bit better on patients to augment lymphatic flow through that area. And then we did what we call a diaphragm release, the diaphragm meaning the prime muscle mover of fluids in the body. So this was meant to treat any kind of hypertonic tissues in the diaphragm area itself, et cetera, and just showing a hand grip for it and a little description of the technique, if you will. A splenic pump, using this over here, a vibratory oscillatory kind of technique over the splenic pump, which is meant to increase the production of immune products, white cells and things into the circulation and into the venous and lymphatic circulation to help fight the infection. Okay. Some previous studies in the profession have done studies just on the splenic pump and measuring these types of white cell counts and things pre and post treatment have been shown to be effective in actually elevating those counts very nicely. And of course the thoracic pump, which we talked about a couple of times already. This is the technique, and you saw the little brief show of it in the video. So that's the protocol that was used. Again, those 5 techniques, 1 minute apiece. Typically, clinically, actually, most techniques like this, we wouldn't time them clinically. In clinical practice, we would just do the technique until we got either some type of response or relaxation of tissues or improvement in breathing or something like that. So we don't do a technique just for so much time, just like you don't do a surgical operation only for an hour. You do it for what it takes. Okay. But we did do this for the sake of the study to put some objectivity and standardization around the treatment protocol. So finally, the results, again, these graphs are all showing, you can see that the treatment group is the OMT group, and basically just roughly going through it, it's always a little bit better than the control group. Okay. To put that in one summary statement, these were the antibody titers. This was the area under the curve analysis that I mentioned earlier, and the area under the curve was always better than those in the control group as well. So again, this is just showing the titer levels again, that type of thing. These are a different group. These are the people that had evidence of a previous exposure to COVID-19. So you can see they already had antibody levels. So even the treatment group was a little better in this group, but they're a little closer because these folks already had a certain number of antibodies. But here in the naive group, the people who had no evidence of previous infection, we got this gradual rise like this all the way out. And particularly following out, we're so many weeks, here's 13 weeks out on this end, et cetera, and on this end. These people were followed for a whole year, and this was consistent through that whole time. Okay, and these were the naive subjects, sorry. So that's where they are with this kind of thing. So it's a similar data response, okay. Symptom frequency, did people have symptoms with their disease? Yes, some of them did. And you can see whether they were, did they have musculoskeletal complaints, GI complaints, et cetera, things like this. So and you can see here the control groups, the amount of symptoms that they had were lower. So even people that may have had a breakthrough infection had lower symptomatology than people who did not have, when they had the OMT, their symptoms were much less than those who did not have the OMT. This is just some more of the same. And again, always people with OMT, not only do they have better antibody titer responses, but if they did have a breakthrough, they had fewer symptoms along the way and fewer adverse kinds of effects. And same way with medication, even if they used other medications, if they took Tylenol for fever or things like that, the treatment group still was much better off than the control group. And adverse effects, there were no serious adverse effects, no deaths, no other kinds of serious mortalities or anything like that over the whole year, that type of thing. So that this went along to, as part of the study, to be able to state that the OMT showed that it was safe, effective. There were no adverse effects to the OMT, no problems with that type of thing. So it's a safely used modality for things. Summarizing the results, higher antibody titers in the patients that got the OMT and under the curve levels as well, reduced medication use, reduced symptom frequency, et cetera, et cetera. And conclusions we had were that we think that OMT shows now that it enhances lymphatic circulation and immune cell delivery, and it promotes early antibody responses, et cetera, and better recovery, improvement in antibodies, fewer side effects by far, and also basically a conclusion that OMT can be used as an effective adjunct. In the beginning, we were thinking that also it can be used as an effective treatment. If you're in a place where there's lack of resources, if we'll call it that way, or if you're treating something like COVID at the time had no treatment. We had the vaccine at this point, but up until that time, there were no vaccines. There are antiviral drugs, but as you likely know, antiviral drugs are only good if you give them at a certain time in the very early part of the infection, and they're not going to cure the infection. They will reduce the symptomatology and some of the side effects, et cetera, et cetera. We did have some limitations that, in other words, we had these antibody titers, we can see the levels, but we didn't know at the time what is a protective titer level for COVID. We never had COVID before, so we didn't know that part. There were new variants that came in, we had to take that into consideration. There wasn't any sham treatment protocol. We had a predominantly Hispanic population, so we don't have the diversity of population that we'd like to see in a more ideal study. And the size, even though we had a large enough size, the study was mathematically powered very effectively, but we'd still like to have a much larger group for further study. And we don't really want to have a pandemic to get a group of patients. We don't need we don't need that. But I can tell you in terms of talking about future studies, we have one that I didn't have a chance to participate in as much as I did in this one, but a study actually has been done on our campus using our veterinary medical school. The students over there are vaccinated for certain types of things, including hepatitis. And so that was chosen as the target vaccine. And so it was basically doing a similar study on these students, collecting the data on a quote unquote normal population. And as I understand it, that data actually has been collected and they're beginning to get started on the data analysis. So to give us a little bit more proof of this kind of study that goes on with these techniques. Here are the references. At the end here, this is the citation for this particular study. I will tell you that I also sent a copy of this study to Global Grand Rounds. So in addition to the PowerPoint that you see here, they should have that study there that could be posted on the website. And if you go on their website, you should be able to download that study. It's an open access. This one wasn't, but we have copies like this. So I think that is all the damage that I can do. I'll stop the share for the moment. Just say thank you, and I appreciate everybody being here. And I don't know if there are any questions, or as I like to say, any questions, comments, or smart remarks that can go on. So,
Great. I'd like to start the remarks by thanking you so very much for the presentation. That was excellent and important information, not only for osteopathic physicians out there practicing, faculty like ourselves, medical students, some of which we have in the session today, and also for medical institutions and health professions training programs throughout the world. Thank you again. And really, I couldn't help but think about the context of this information pertinent to telemedicine, served individuals you mentioned, under-resourced environments, et cetera. And most of those environments involve under-resourcing of on-site clinicians or community health workers who have or don't have this type of knowledge or understanding or training. So first question is regarding opportunities amongst the challenges of deploying this kind of training experience and applying it to those in need, either folks being vaccinated for COVID-19 and other diseases, but also those who are unfortunate enough to be afflicted by it. And so question number one is, might there be a role for telemedicine, this same type of platform that we're using right now in its most basic form, audio, visual, and the opportunity to collaborate on implementing strategies that diminish suffering, morbidity, and mortality from conditions like this? So is there potentially a role from your perspective leveraging telemedicine for the dissemination of this information over and beyond a session like this, and also training folks at the point of care, everywhere from licensed physicians to community health workers and perhaps even family members and or the patient themselves? Might there be an opportunity to train individuals in short work in a short period of time to gain some competency in performing lymphatic pump techniques on a loved one, on a friend, a family member, or even on themselves?
Yeah, that's actually a great question. And in my circles in the profession, there's been a lot of discussion about that. So on the one side of it, and I include myself on the one side, when it comes to learning a psychomotor skill, as I would call OMT, there's not really a substitute for a face-to-face, hands-on learning, just like your clinical skills. It's hard to learn how to do physical diagnosis without physically being present with your teachers and your patients to do that. On the other hand, if you think about remote areas of the world where ready access, you can't just go to a medical school down the street and take a course or something like that, or have a course come to you, then sometimes I guess necessity is the mother of invention, and it has to be done. Also, to put against that, ever since I've been in a profession, I hear DOs saying you can't learn this by video or being present, but at the same time, they have commonly taught patients certain things. So if you have a child, let's face it, in the 21st century, it's pretty hard for a physician to have, say, a sick child or a sick patient with a respiratory disease and think that you're going to be at home with them at the bedside so that you can do lymphatic techniques every 4 hours or something like that. So these techniques, as you saw, I know it was a very brief video, but they're not difficult, they're very safe. And so it's not uncommon for DOs to show a family member or somebody how to do a lymphatic pump technique or a rib raising, which we didn't show in here, but it's another technique. And that's something that they can do at home. Somebody can do that safely and have this effective response. So there's a way to do that. I would also add in here, I thought about this, so I hope this is kosher enough. There's a DO in New York named Susan Milani. I will spell her name, Milani. I know her very well. And during the pandemic, during the lockdown, when she couldn't be in the office, she did a kind of telemedicine. She and actually her husband at home made a video of some of these techniques where she converted a lot of these techniques to self techniques that she could perform on herself. And so she made a video of this. And with her patients, she would get on video with them and show them the video and coach them through it. And then they could get on, the videos are on YouTube, so the patients could go on YouTube. And then the patients at home, either themselves or with somebody with them, could do a kind of protocol like this on themselves. This was during the pandemic, before the vaccine was available. I would say if you remember the name, just Google her name on YouTube and they'll come up. The video was popular enough that it actually got translated into Spanish and I think Chinese and even Tagalog. And maybe more languages. So there's some people would raise a kind of controversy about people trying to do this on their own or learn it from a video. But under some of the circumstances, particularly in the beginning of the pandemic we had, something like what Dr. Milani did came in pretty handy for people. Those are some ways that if you look on the web, I would say the only thing about the web, and obviously being biased, I would look for some of these things. And if at least they're being demonstrated by an osteopathic physician who would obviously be trained. Our students spend a couple of years on campus learning these techniques before they even go on rotation. So they put a pretty good amount of time into it. But they are relatively easy transferable and those kind of things. So I think there's opportunity and maybe necessity on both sides of that.
Great. Thank you for that. Appreciate it. I do have one more question, but I want to leave space and time since we're coming up to the end of our hour here pretty soon for anyone else to ask a question. And then I have one final one. All right. Hearing none in that Zoom silence. Yeah, I couldn't help but think what happened during the pandemic, especially during the early phase. And one example of how musculoskeletal and somatic functional dynamics actually impact the immune function of the immune system. The studies we saw today, one amongst a number of those that attest to that reality. And lo and behold, during the pandemic, we all remember, especially those of us who witnessed and participated in some of the early discoveries of proning patients. So these are sick people with severe COVID, life-threatening COVID, many folks that were intubated in ICUs. And those of us who were around and practicing during that time recall proning being discovered as a technique. Mm-hmm. Might there be some thinking about using proning as a kind of a surrogate approach or technique to improving survivability from COVID, better outcomes, reduce morbidity and mortality? Could it be that proning itself was liberating lymphatic fluid, improving throughput in a way that was also augmenting the individual's immune system response to treatment? This was before there was a vaccination.
I heard some discussion about that at one meeting, and I guess the short answer is people wonder the same things, and we're not really sure. I guess we'd have to figure out how to study that. But you could think that way. If the patient is prone, there must be something about that might be doing something for the immune system, possibly. If you thought about doing some of this stuff, we think of the patient being supine most of the time. But if they're prone, I don't know that you couldn't put some gentle pressure posteriorly on their chest wall and do a similar kind of movement of fluid, even a posterior approach to the diaphragm to some extent. And in the Spanish flu days, the DOs did things like even had the patients doing just ranges of motion with their extremities, or they did passive motions. So just that additional motion is helpful. There was I know you're talking about a very sick patient, but just thinking about motion of the extremities, there was one study published a little while back that showed that possibly one of the best things you could do after you got a COVID vaccine or a COVID booster is go for a 90-minute walk. Those people had higher levels of antibodies after the COVID shot than people without walking. Physical activity, if you want to put it all in that classification, has a good effect on that too. So,
wonderful.
And by the way, it's off of your question, but just so I can say it, that this kind of stuff, as you probably can figure, I would think of this as for almost any kind of process like this. People get the flu every year. They get head colds and things like this. You don't need a pandemic and suffer to do this technique. You can, it takes a couple minutes to do a treatment on them. You can show them a couple of things to do at home. You can help people get better of all of these things. That's transferable to more than one virus, I think.
Thank you, Dr. Hruby, and looking forward to more in the future like this. Maybe a session dedicated toward demonstration of these
Sure.
techniques. I'd be
Yeah.
first to volunteer. I'm due for a COVID vaccine,
Okay.
by the
Yeah, we have
way.
done that
And
before. That's right.
yeah, anyway,
All right.
appreciate your collegiality and excellent presentation so very much. So thank you again.
Well,
And
thank you. All right.
you bet. Back to Katie to close.
All right.
Yes. Thank you, Dr. Hruby, for sharing your expertise with us today. And thank you to Dr. Peckiel for leading today's discussion. We would like to thank all of you for joining us and for your continued interest in the Global Grand Rounds. A recording of this presentation, along with an AI generated summary of the discussion, will be posted after the session. We hope you will join us for our next Global Grand Rounds on June 10. Thank you again for watching, and we look forward to seeing all of you for our next session.